Welcome to the almost last session of the today, and we have actually experts in coronary surgery from Japan, Professor Hirofumi Takamura. He is the current president of Japanese Association for Coronary Surgery, right?
That's right.
Yeah. So his first talk is about surgical strategy for total arterial, combined, or total venous CABG. Please.
Thank you very much. Thank you very much for your kind coming to this session. I'm happy to have you. But, I'm sorry, I have to apologize that some slides are covered with my postgraduate course session. So anyway, I want to start. So what is the optimal graft selection for the CABG if the patient has 3-vessel disease? Historically, we started with the subcutaneous vein, and we started to use the litter around 1919. And around 2000, we started to use the bilateral mammary artery. So this is the total venous bypass. And this is the combined CABG. And also, these should be the total arterial revascularization in CABG. So, looking at the European guideline, there's 5 comments about the conduit selection. One is arterial grafting with a mammary artery, and one is a bilateral mammary should be used in the patient under 70 years old age. And the usage of the radial artery is recommended only for the target vessel with a severe stenosis. And the total arterial recommendation for the poor vein with the patient with a poor vein, and also the reasonable life expectancy. But in 2018, it was changed a little bit. And they compacted about conduit selection, but there are only 4 sentences. So if I compare two guidelines, ITA to LAD is same, radial is same, but you can see that the total arterial revascularization, the sentence was disappeared. And the recent guideline said only additional arterial graft, not talking about the total arterial revascularization. It's very interesting. All of you know the CETA, ITA carries a very good result compared with the SVG, is 20 years results. And also the beta is better than the CETA. It is 12 years result and 20 years result, and also 30 years old, 30-year follow-up showed a very good, better result on the beta. But recently, this is the first and only RCT by David Taggart, concluding that there was no differences between the beta and the CETA in 5 years, and also 10 years. But recently, he published a paper about consideration about the meaning of the beta. So 36% of the patients received a different treatment strategy, meaning that 14% of the bilateral ITA close to the single ITA, and 22% of the single ITA group had a second arterial graft as a radial artery. So if he did as treated analysis, there is differences between the real single arterial graft and the multiple arterial graft regarding the mortality, and also the death and MI and stroke at 10 years. And also the Mario Gaudino said that the ART trial didn't show any differences between 2 groups, but the finding in the contrast, the results of most observational study showed a good improved survival. So they reconstructed the data of the observational study and compared with the ART trial. And finally, they said, even if the results between the beta and the CETA same in the ART trial, by observational trial showed much better results for the beta group rather than the CETA group. So it's very interesting. Regarding the radial artery, Mario said again that he used a combined analysis from the 6 studies and said additional radiography carries a good result compared with the substance vein graft. So it's very controversial. And also we should take care for how to use the radio. If you see the radiography, the substance vein doesn't matter whether the native coronary artery stenosis, but if we use the radiography for the moderately diseased coronary artery, the patency is not good. So we should think about the size of the artery and also the native coronary stenosis also. How about the GEA? We reported that the diastolic pressure of GEAs is much less than ascending aorta pressure. It is one of the not good point of the GEA. And also, if the GEA was anastomosis on the moderately stenotic artery, the patency is not good. And Professor Asai groups told that skeletonization method is very good for the GEA. And also, we reported also the efficacy of the skeletonization of the GEA, like this. And also, we reported some bad cases. The patient had a coronary steal after the operation because of the stenosis of the gastroepiploic artery. Because due to the stenosis, the blood was stolen to the GEA. And also, if the patient had some stenosis on the gastroepiploic artery, the heart was not relieved from the ischemia. We need a reoperation with a venous graft. And also, this is Professor Sakata reported that if the patient have a bilateral mammary artery to the left coronary artery, even if we use the GEA, the result was same with the SVG, which was bypassed to the right coronary artery. Just showing how to take out the GEA. So just elongate the incision 5 centimeter for the abdomen. And using the scissors type of the ultrasound scalpel, it's very easy to take out the GEA. And after that, I skeletonize using the diasami and also the hammer scalpel like a knife, like this. So next slide is my typical total arterial grafting. This is maybe a 4 minutes video. So this is a writer. I usually harvest the mammary with a semi-skeletonization. I mean with a vein, no muscle. And this is the liter. So marking not to twist the artery, and I use a big curved forceps to catch the writer and passing through the transverse sinus. And I studied the anastomosis on the obtuse marginal. I put an elastic stitch to have a good hemostatic operation field twice. And also this string was attached to the pericardium to make the artery straight, as straight as possible. So putting the graft on my original holder and preparing for the anastomosis, I make a small hole on the artery and put a string. It can make a no bleeding field. So after putting in the internal shunt, I started the anastomosis like this. So this is a writer to circumflex. And in this case, next anastomosis is GEA. Also, usually, always I check the TTFM, and also I try to see the figure of the anastomosis using the VeriQ system or ordinal ultrasound scanning. So you can see the very good anastomosis site and also the flow, like this. So next anastomosis is the GEA for the PD. The anastomosis technique is almost same, putting in the internal shunt and using the A2O monofilament stitch with the running suture technique. And finally, again, check the TTFM flow meter and also see the figure of the anastomosis using the ultrasound scanning. So you can see the good GA inside and the anastomosis figure. So this is the final anastomosis to the liter to LAD. Samely, the putting the stitch for the hemostasis. Putting the internal shunt. And anastomosis too. So a form is not so. It is not a circus. It's a standardized technique for us, and just continue. Any internal shunt make the heart stable. I use the backhand for the far side for the anastomosis, and use the forehand for the near side of the anastomosis. So after leaving the shunt, the elastic stitch can stop the bleeding, so it's very comfortable for me. So maybe one or two stitches before I remove the shunt, so the proximal was closed automatically by a string. So this is our standard technique. So what is the role of SVG? Then SVG is still a good graft, and because the SVG is widely used for CABG, because it has a it is long enough and good. It has a good carrier. But the problem is that the vein graft failure maybe 15% in 1 month and 50% in 10 years. Because of the early graft failure caused by technical failure thrombosis, and midterm graft failure by intimal hyperplasia, and long-term graft failure by atherosclerosis. This is the reason why the SVG failure occurs in the early phase. It's endothelial denutation, and 1 week it's smooth muscle cell proliferation. And after finally, the intimal thickening and superimposed atheroma would occur. So in Japan, this is a real number of the distal anastomosis. Even though we say we want to use the bilateral mammary, but the real world, we use the liter in 40% and the writer in 16%, and the GE and the radial, the number is very decreased. And also, we still use the SVG in terms of the distal anastomosis graft. I'm sorry, data is a little small. So this is my real world number. So during the 2 or 3 years, I did around 300 patients of CABG, and elective and multi-vessel bypass was done in 177. So I divided the patient into the young patient under the 70-year-old and the elder group 70 years. So the number is 91 and 86. So I just review my technique. So the total number, no, I'm sorry, the mean age is 61 and 76, and it's okay. So next one is, so I used liter in a young group, 80%. Even in the elderly group, I used liter 95%. And I used beta around 70% for the young group, and only 24% for the elderly group. And still, I have to say that I'm using the surface vein for the young group for the total revascularization. And what was grafted on the LAD? In the younger group, liter was, and the liter writer was used like this, and only one patient, which was shown later, he had a polyarteritis nodosa. I had only one vein to the LAD. But even for the elderly group, I used over 95%, I'm using a liter. I skipped the diagonal now. And for the circumflex, in the younger group, I was using arterial graft about 90%, but for the elderly group, I'm using the arterial graft only 33%. So maybe I selected the patient for the multi-arterial grafting. So for the right coronary artery, even for the young group, I was still using a vein graft in 60%. It depends on the native coronary artery stenosis. So regarding the RCA, the maximum RCA stenosis was much small in vein graft patient. The result was okay. The total arterial was open. Just one graft of the GA was occluded. And the surface vein patency was also over 90%. And we are very happy with the result. And there was no mortality, no stroke, and no reoperation for the bleeding. So how to reduce the venous graft failure? One is a no-touch technique reported by Souza. So if we have a graft skeletonized, you can see the graft spastic in the lower figure, they say. So they started to use the pedicule vein. So he came to my town last week. So looking at and also the morphologic analysis, this is the left side is a normal vein, and the center is skeletonized technique. It shows laterally the atherosclerosis, and the right was no touch technique. It showed no atherosclerotic change, he said. So this is a meta-analysis of the no touch technique. So using the Dr. Kim's data and SOTA technique, the patency rate of SBG is better in no-touch technique group. And the long-term clinical outcome after CABG with the pedicule surface vein, so two propensity score much cohort they reported. And they said, but they alerted that even if we use the no-touch technique, the long term regarding the survival did not change at all. So we should take for the long-term result as a survival, not patency. So this is the European guideline in 2018. They said no-touch vein harvesting should be considered when an open technique is used, because they recommended some endoscopic one. So if we use the endoscopic technique, it's very difficult to have a pedicule vein. So we studied the pedicule vein graft. So with a match of the connecting tissue, we started to use the no-touch technique. So this is anastomosis for the ascending aorta using the devices for the proximal side. This is a little bit of a typical case. The vein graft is going to the circumflex and also the PD. It's very good, long enough. and this is the sequential graft. So just to expose the vein out of the surrounding tissue, we can do the sequential graft or even if we use the pedicle graft. So this is the final anastomosis to the PD. The patient is a little typical patient. So this is the anastomosis for the PD using the pedicle surface vein. And also David Taggart reported the external stent for the vein. I'm not sure about that, but they said that morphologic, the external stent keep the good size of the vein. And also this is the dual graft solution. It is not available in Japan, but they said this graft solution is very good for the good patency of the surface vein. So we should think about how to avoid graft failure, because we still use the surface vein for the multiple vessel anastomosis. So who needs the really total venous cabbage? I reported the two cases. One is polyarteritis nodosa. So this is the recommendation by guideline for the poor vein. I'm sorry, this is another misunderstanding. So the patient is only 38 years old with polyarteritis nodosa. He had many aneurysm on the coronary artery. And also, interestingly, his internal mammary artery was occluded, and also the radial artery was take off very high level, and the GA had aneurysm, so you couldn't use the mammary and the radial artery and the GA at all. So I did only 2 grafts by a vein. There was no option. I have to skip. The time is running. So this is this is the finding of the ITA. It was very sclerotic. So I did only 2 grafts, but unfortunately the graft to the OM was occluded, but the patient recovered very well. The histological finding was compatible to the PN. The final case is this is a Sappho syndrome. It's a very rare syndrome. It's called Sternoclavicular Hypostasis. I had one case with a 78 years old guy who had a very thickened sternum like this, and also after cutting the sternum was completely bone without no bone marrow. And also the IMA was stuck in the connecting tissue. I couldn't take off the mammary. So I did the vein grafting to the LAD, and also the proximal side retard connecting with the vein to the PD and the CX. I made 3 vessel anastomosis. So finally, the total arterial that sentence was disappeared in the recent recommendation guideline. Maybe it's saying that we should think about how to use the substance vein graft. So we should improve the quality of the substance vein graft. So this is the conclusion. SVG is still widely used for the multiple grafting. And when ITA was used for the LAD, the long term is very good. And the reason or the benefit of the second and third of arterial graft is still controversial. We should pursue the way to improve the SVG quality and the long-term patency. Thank you very much for your attention. Thank you.
Thank you. This is a very comprehensive review, and now the paper is open for discussion. Any questions? Yes, please.
Hello, my name is Franz from Germany, and our Our experience is actually quite similar to yours. In Germany, the use of the beta is strongly advocated, but if you look at the national quality database, the veins are still quite popular. And what is your strategy for the storage medium? Because you mentioned that like the one storage medium that has been developed for the veins is not available in your country, and there are multiple recipes. Some like to store it in heparinized blood, and some use custodial. So what are you doing?
Thank you very much for the question. It's very difficult to understand and answer you clearly. But my real daily technique is I want to try to use the bilateral mammary artery, and the third graft for the right coronary is very controversial even for me. So I decide for the younger patient, maybe under the 75 patient, I want to use the radio or GA, and for the patient over the 75, I just put a vein graft. But for the vein graft, I started to use the pedicle vein graft. But I have not yet have a long-term result, so I want to try to have a long-term result. Did I answer you? Did I answer you? Your question?
Yeah, partially. When you have removed the vein graft, do you have any storage medium where you put it?
Yeah, I usually do an off pump. So initially, I take a vein with a pedicle, and first I put a vein on the ascending aorta. So the vein is expanded with the patient pressure only. I don't extend the vein manually. Otherwise, no clip, no.
And congratulations! It was a nice presentation and a huge literature overview. And my question is, how do you think, or for all of you, what's the reason that in 2018 guidelines, total arterial revascularization disappear? Do you know a reason for this?
I won't ask you. You're a European guy. Anyway, honestly, I read the guideline recently for this presentation. So I noticed that, that sentence was disappeared. So I just after that, I really think about it. Anyway, it is very difficult to show the differences between the theta and beta also, as Tagat said that. But my experience, the beta should be better. It's my experience. And for the young patient, the third arterial grafting should be better. But it was very difficult to show by a randomized control trial. But many observational studies emphasize that additional arterial growth is better. But just only additional to as a second graft. But the total arterial means that maybe the third arterial graft, it looks very difficult for the scientifically to prove looks very hard. So it's idea why the sentence disappeared.
So
I don't know.
I think it's it's my thinking now. Probably all these guidelines are based on research which are done in total arterial vascularization. And we know in the United States of America, many surgeons are doing one mammary artery and veins. So only about 5 to 7% of them are using total arterial vascularization. Yeah. Even in Europe also, it's about 15 to 20% of surgeons are using 2 mammaries. So probably, and publications also are in this direction. In Japan and in Asia and in different countries in South Korea, are now more than 40% or 60% surgeons are using arterial vascularization. In my knowledge, maybe it's not true, but I know.
I think one reason of economic. Maybe you know that there are many institutes in Japan, and we are doing a small number of the patient in each institute. So we can focus on the one patient a day. But in a European country, you should do the 2 or 3 cases in a row. So they are rushing to how to finish earlier. So, but any bilateral mammary needs some longer time in the theater, and also the very important thing is that to show the difference between the theta and beta, it needs maybe more than 10 years. 10 years. But if the patient has only one ITA, the long term is very good. Even the patient has 2 vein grafts. So.
Yes.
Professor Yokoyama maybe need to make a comment.
I will answer.
But I like to congratulate you. You are very excellent. Just one question about the complete arterial revascularization. I understand some of the patient needs complete arterial revascularization, but there are 2 things: all inside to arterial revascularization, the other, like I graft or T graft or using a Y graft. Do you have any opinion on that? But, this question is because we Japanese surgeons are rarely using Y graft right now because some Japanese doctors are reported already there is some competition or string sign of the Y graft in the long-term period, but some other countries, surgeons are using a Y graft many times. So what's your opinion about that?
As you know, around 2000 in Japan, we tried to use no touch, no aortic technique. So for that, we made many composite graft. I used to be, but recently I don't use the composite. I try to use the inside mammary artery, but if the right letter is short, I cut off the letter, put on the aorta, not composite. I don't impair. I don't make the composite graft on the LITA to LAD graft because the LITA ITA LAD is a gold standard, and I want to try inside to and or direct AC bypass.
So you rather use the vein graft rather than Y or such a complicated
That's right. Yeah.
arterial graft. Okay, thank you.
Thank you.
Thank you very much.
Thank you very much.
ありがとうございます。
Yeah. So, where's my computer? You have a computer? No. I just need to forward like this.
So maybe I can introduce the next speaker. Next speaker is Song Wang from Taiwan.
Yeah, thank you. Thank
There's
you.
a moderator here. So
And
please start your lecture.
Tavisa gave me this topic, on versus off-pump CABG, a prolonged debate with any conclusion. I was thinking, no, again, because for the last few years, I was debating all the time. Last year in Japan, I was debating with Dr. David Taggart about on-off pump. I thought this debate should be finished, but every meeting, still people keep going on talking about this. So, where? Yeah, I have no disclosure. That's why. So I read this comment in one of the editorial commentary, and it said more ink than blood has been spilled in the off-pump, on-pump saga. So people keep debating, but actually there is no result. The one who love to do off-pump keep doing off-pump, and the one who do on-pump keep going on-pump. I don't see any change. So even JDCVS, there was a commentary. Can we settle the on-pump or off-pump debate with more than 1 million patients? He was referring this meta-analysis with total 1.2 million patients. And this is an interesting meta-analysis because not only the randomized trial was included, but also 31 rigorously adjusted observation study was also included. And interestingly, the result is like this. Off-pump had lower short-term mortality compared with on-pump. But off-pump get worse long-term survival compared with on-pump. So you can't say off-pump doesn't have any advantage. Off-pump, short-term wise, seems better than on-pump. That was 1.2 million patient experience. So I just give you one example because I come from Hong Kong, and I give you a Chinese example. This paper is from Fuwai Hospital. This is the #1 cardiovascular institution in China. They do 14,000 open heart cases per year. So this is paper published in Circulation 2010. They compare their own experience in more than 6,600 patients, consecutive patients, no selection, on-pump, off-pump, mean follow-up 4.5 years. And they showed off-pump patient within 7-8 year follow-up had more major vascular event compared with on-pump, had more repeat revascularization compared with on-pump, and more importantly, had more recurrence of angina compared with on-pump. And this is a large patient population, more than 6,600 patients. And that's from the #1 institution in China. But what's the result? They result in no change, even in their own institution. After the paper published in Circulation, look at the subsequent years. Off-pump CABG, still more than 55% total CABG patients in Fuwai Hospital. Those off-pump surgeons in Fuwai Hospital, they ignore their own so-called evidence. They keep doing off-pump. So you can say, well, that's an institution retrospective, non-randomized study. Let's look at the randomized study. This Cochrane review, published in 2012, summarized worldwide all randomized study, regardless the language. If it's published Spanish, if it's published in whatever language, it's all included. So total 86 trials, more than 10,000 patients, and the authors select 10 trials, the so-called best evidence. And the conclusion, look at that. Off-pump CABG increased all-cause mortality. Off-pump CABG result in fewer distal anastomosis, so indicating less complete revascularization. And there was no difference between off-pump and on-pump in terms of myocardial infarction, stroke, renal insufficiency, re-intervention. Off-pump CABG carries no advantage at all from all the randomized trial. But this paper, actually, not many people cite this paper. I think the off-pump surgeon, on-pump surgeon, they actually are talking different patient population. They don't agree with each other. This is a very recent Danish on-pump, off-pump randomized trial. More than 900 patients, elderly patients, age more than 70-year-old. And the conclusion is actually the graft patency after off-pump surgery was not as good as on-pump. This is another randomized trial. And graft patency, only Lima to LAD, actually no difference. If any difference, off-pump may be even better. Lima to LAD, off-pump, better than on-pump. But all the other graft, the patency rate worse in the off-pump group. This is a meta-analysis from Japanese group, very professional for meta-analysis. And this paper is about 5-year follow-up, all the randomized trial, 22 studies, more than 100,000 patients included. 5-year follow-up, off-pump, worse survival. You see, all the studies, 5-year follow-up in favor of on-pump. And then a few years later, they published in American Journal of Cardiology 2017, 10-year follow-up. All the trials, again, favor on-pump. So when you look long-term outcome, always the on-pump group better than off-pump. And so far, in the literature, there is no single paper, even from the world-renowned off-pump surgeon, they demonstrate long-term survival off-pump is better than on-pump. Maximum, they say, off-pump is not inferior compared with on-pump. But they never provide any evidence long-term survival off-pump is better. Long-term outcome, on versus off-pump, CABG. This is published in the Journal of American College of Cardiology 2018. Look at the result. Again, it's in favor on-pump. Pascas, off-pump master surgeon, saying, okay, off-pump is operator-dependent procedure. We have some off-pump expert here. You ask them to do off-pump, it's as good as on-pump. And not for every patient or not for every surgeon. Is that good enough? What's operator-dependent, good or not? Any surgery, in fact, is operator-dependent. Even you remove infected appendicitis, it depends on surgeon's experience, right? Operator-dependent is for every surgeon, every procedure. And apart from operators, is there any difference between on-pump, off-pump? Actually, nobody can give us a clear evidence. David Taggart, suppose he should be here, co-moderate this session, but he didn't come. 5 years ago in Hong Kong, the same meeting, Asian Society annual meeting, he said, if it was not for the IMA, there would be no CABG today. Why? Because IMA give you better long-term outcome. So CABG, the most important thing is reproducible long-term survival benefit over PCI. If you don't have this benefit, CABG will no longer even exist in this world. Well, look at this paper. This is the brand new, published last year, 2019, the Excel trial. The last author, David Taggart. The second author, John Pascas. Look at the others like Jill Sebek, Gianni Angelini, all off-pump experts. And this is a paper from the Excel trial. Study left main coronary disease. Look at the survival curve. 3-year follow-up. The death rate in the off-pump group much higher than on-pump. This is the Excel trial in left main patient population conducted by many off-pump experts. The conclusion by those off-pump surgeons, John Pascas, Jill Sebek, David Taggart. In the large-scale randomized multi-center Excel trial, despite comparable extent of coronary disease between the two groups, performance of off-pump surgery was associated with a significant lower rate of grafting of the left circumflex and the right coronary artery, and 2-fold increase in all-cause mortality at 3 years compared with on-pump. David Taggart, last time in Japan, debate with me about on-pump, off-pump. He didn't mention this one. Okay, Dr. Svensson wrote an editorial commentary. Off-pump CABG fails to excel in surgical revascularization of left main disease. This is the conclusion, 2019. And another paper published in the Annals of Thoracic Surgery, 2019. This is in diabetic patient population, compare with off-pump and on-pump. Look at the result, 5-year follow-up. The survival on-pump is significantly better than off-pump. Diabetic patient population. The conclusion of the authors, with a 6.1% absolute difference, a strong trend toward improved 5-year survival was observed with on-pump CABG for medically treated diabetic patients. No off-pump advantage was found for any 5-year endpoint. A future clinical trial now appears warranted to rigorously compare off-pump versus on-pump longer-term outcome for diabetic patient. Again, the evidence in favor on-pump. So, Tavisa asked me saying, a prolonged debate with any conclusion? I think the conclusion was there, not even now. A few years ago, look at the conclusion. This is from Dr. Smith, a famous off-pump surgeon. He said the party is over. He said, compare with on-pump. Off-pump CABG is behaving more and more like PCI in multivessel disease or diabetes, except it lacks any of the obvious benefit of a procedure that is truly less invasive. I say this from the perspective of a surgeon who has been doing more than 80% of his coronary procedure off-pump. This is the off-pump surgeon's conclusion. The party is over. Giuseppe, off-pump surgeon, his title, on-pump coronary revascularization should be our preferred surgical revascularization strategy. It is time for us to admit, despite our best effort, we routinely cannot do as good a surgical revascularization off-pump as we can do on-pump. This is from Giuseppe, off-pump expert. David Adams, last year, on-pump CABG in 2018, still the gold standard. So do we need more conclusion? This is a statement in New England Journal of Medicine. I like it very much. We need to be sure we do not sacrifice proven long-term effectiveness for short-term issues like convenience, invasiveness, reversible procedural complication. The goal is to make the patient feel better and live longer. So think again. For CABG, you want better long-term survival, or you want a few so-called short-term, less complication. Thank you very much. Questions are welcome, especially from the off-pump surgeons, please.
Well, thank you. Very convincing lecture. I'm very impressed. Any cardiologists who refer you a Cabg patient ask you go on pump?
In our institution, no cardiologists ever ask for any patient go off pump. So it's your decision on pump or off pump.
So you mean it's up to you?
Yeah, they don't ask for off pump. They don't ask for on pump as well.
Neither.
It's up to you to decide.
Well, that's agree. My cardiologist never ask me to do something on pump or off pump. It's curious. Yeah. The other thing, I'm a off pump believer because theoretically you put the graft to any area without cardiopulmonary bypass or cardiac arrest is the best way. If you do the best way, so the off pump is theoretically right and perfect. And reason number 2 is in our history of the thoracic surgery or cardiac surgery, maybe 10 years ago or 100 years ago, some doctor said, okay, thoracic surgery is done, it's over. And it just 20 years ago, when first stage of Cabg, there is a trial of off-pump Cabg. Then but it's disappeared. And 20 years later, in some way, somehow, off-pump Cabg is now coming up and now in the debate. So I hope this theoretically perfect surgery should be real perfect, real effective in the near future. Thank you.
Yeah. I give the last 20 minutes presentation, just try to prove this is not a theoretical perfect procedure. So I agree, off-pump still should have a room. I'm not saying I do CABG 100% on pump. It's interesting, in Japan, more than 60% CABG still off pump. In China, more than 55% still off pump. In India, I think more or less the same issue. A lot of CABG still doing off pump. But you look at Europe, you look at North America, off pump is very rare. It's something like 10%. In Germany, 0%. Almost 100% on pump. Well, the evidence so far, as I said, you said that's a perfect procedure, but you never able to provide us long-term survival better in the off-pump patient. All the off-pump surgeon, they debate based on short-term outcome. I agree, if the patient cannot survive short-term, there is no long-term to compare. But the problem is, off-pump seems now only in favor in those master surgeons. For young generation, when they start to do CABG, on-pump is much safer. You say without CABG, without CPB is a benefit, people may criticize, we may debate with you, because CPB now is a very safe procedure. With cardioplegia, myocardial protection is very safe. On the contrary, off-pump CABG is a very stressful operation. Anesthesists cannot go to the other room to drink coffee because they has to be there, they control the heart rate, they modify the BP, they really need to collaborate with you. On-pump CABG, they can go to the other room to drink coffee. Yes, please.
I think, thank you very much for nice presentation, and it's just like a debate. Anyway, guideline recommend less manipulation on the aorta. If you put a patient on bypass, you should touch the aorta. If you can do the completely no touch aorta, why don't you try to do no touch aorta?
Okay.
So, and one thing that we are now collecting the Japanese database among the over the 10,000 patients. We're not just about to publish a paper talking about the long-term result. And it would say there's no difference between the long-term and between the off-pump and on-pump in Japanese database. It's not yet published, but we are not just about to publish. And as Pascal said, maybe off-pump is not universal, not for the all surgeon, not for all surgeon patient. But as you know, as Pascal said, for the very high-risk patient, we should choose off-pump, not all patients. Very selected, very high patient, we should prepare do off-pump. If the patient has a bad aorta, how do you put the patient on the pump? If you can do the off-pump, no touch aorta, it should be better. So for the very selected patient, we should prepare off pump.
That's why.
Don't do on pump all patients.
That's why I was saying off-pump surgeon and on-pump surgeon, they are talking about different patient population. And how many CABG patients really have very bad aorta? 100 CABG patients, how many patients got really bad aorta? You cannot
It
tell.
depends on the degree of disease.
And
Complete normal aorta is very rare.
yeah. And look at the evidence, on-pump, off-pump. So far, there is no evidence indicate off-pump get less stroke. Even you don't touch aorta, even you do so-called total arterial grafting, off-pump is not without stroke.
I had a publication in 2004 talking about it's a real only one randomized study from Japan. We compared with just 400 patients, but we published a paper talking about not stroke. It's 100 protein 100 level is higher in on-pump cases, but no difference on the, between the stroke.
Troponin level.
Yeah, just that. No, it's a protein 100. Protein 100. It's a parameter for the brain ischemia. Something.
Okay. In 1999, our group in Hong Kong published paper saying troponin level post-CABG is lower in off-pump group compared with on-pump group. And our paper has been cited many, many times by those off-pump advocates, even confirmed by the randomized trial. But the problem now is, I just mentioned 1.2 million patient comparison. There is no difference in terms of stroke. There is no difference in terms of myocardial infarction. There is no difference in terms of renal failure. There is no difference in terms of reintervention, but the survival is better in on-pump group. So you are talking about 400 patients. That was 1.2 million patient. And 80 some randomized trial. So that's why I think this debate probably will going on forever. The conclusion is there. Whether you accept it or not, it's your problem.
Yes, very interesting. So I'm on-pump surgeon. So I have about 0.6% mortality in CABG without any associated pathology. And I didn't switch to off-pump surgery because I had a good results and I didn't switch. Probably surgeons who start with on-pump surgery, they will do on-pump. Who start with off-pump surgery, your residents probably will do off-pump surgery. My resident will do on-pump surgery. But here, probably there are any advantages for off-pump surgery too. Because you can do faster, you don't go on bypass, you don't go out of bypass, so you have more time. Probably it's cheaper, and in many countries it's important to do cheaper operation than very high price to pay for this. But your argumentation and all this data, 1.2 million people, is about on-pump surgery. So also another argument may be this patient will come in 5 or 10 years. He will come back, and we will have to do. We will be on charge. You will do another operation, or somebody will do another operation. There are many advantages and disadvantages. But the main advantage for on-pump surgery is long-term survival. If patient is living more without any complication, so it's a supreme advantage in my opinion.
Yeah, I hope this is the last debate. Next year, the annual meeting, I don't need to talk about the same topic. Thank you very much. Okay, our last lecture by Professor Yokoyama, Stabilization in off-pump CABG. Key approach for safe and best outcomes.
Well, thank you very much, Mr. Chairman. Well, I like to talk to you all night long. Well, this is a great privilege for me to present such an important topic. Okay, here we go. Well, as you may know, the off-pump coronary surgery bypass is a microsurgery in which the surgeon works on small moving object. Allow micro stitches on the small vessel may result in graft stenosis and occlusion. There are miscellaneous, many factors affecting coronary artery motion. Here, that's heart rate and cardiac contractility, coronary artery anatomy, surrounding fat, adjacent organ movement, and mechanical stabilization or pharmacological effects. So every effort should be paid to avoid or control these factors for better stabilization. Here is a hypothesis on the relationship among stabilization, surgeon skill, and graft patency. As a trainee must have almost a perfect stabilization to get a good anastomosis and good patency. Expert can manage to some motion of the anastomosis site, get a good patency. So it seems there are two factors, stabilization and surgeon skill for better patency. My colleagues developed a three-dimensional digital motion capture and reconstruction system, which is an application of modern robotic technology. Two high-speed camera capture the marker on the beating heart and sending a two-dimensional data to the computer, and there reconstructed the three-dimensional position data. Here is the image of the two-dimensional data, two-dimensional XY data from two cameras, and constructed to the three-dimensional XYZ movement. Does it look like a same? Okay. So this is an example of free LED movement. Very fast, complex movement. So the coronary artery movement is such a fast and complex movement. We set parameters for motion. In a single heartbeat, how far the point of interest moved is represented by distance. Okay? How far the point of interest moved is represented by speed. And how quick the point of interest moved is represented by acceleration or deceleration. You can see that we are still working on the moving field. Surgeon with some experience can manage that, I believe. But however, I'm not sure a trainee can manage this anastomosis. So the first question is, how does this stabilizer work? As you may know, mechanical stabilization is powerful and local. There are many types of stabilizer. I prefer this type of stabilizer because it's auto spread action. Here is the result. In this case, the mechanical stabilization is done by octopus. Can reduce the distance moved during one cardiac cycle remarkably, like this. While the rapid sudden movement, such as maximum velocity, acceleration, and deceleration, are not decreased much. In other words, sudden quick motion remains even after the most recent sophisticated mechanical tissue stabilizer. One of the efforts to decrease this sudden quick motion is pharmacological stabilization. It's gentle and global. Here shows adrenergic receptor system. As you know, beta-1 receptor blockers decrease heart rate. It means negative chronotropic effect. And myocardial contraction force means negative inotropic action. The target coronary artery is just sitting on the myocardium and fat tissue, so we can have a hypothesis that myocardial contractility affects coronary artery motion. And now we have three types of intravenous beta blockers. Let's see the detail of this drug. Propranolol is the first generation beta blocker, having a very, very long half-life and non-beta receptor selectivity. Esmolol has a shorter half-life and beta-1 selectivity. Landiolol, this is a new drug developed in Japan, has much shorter life and strong beta-1 selectivity. Unfortunately, Landiolol had a dose range that decreased heart rate, but not blood pressure. I think this dose range is convenient for off-pump surgery. Here's one example. The left panel shows the movement of coronary artery of 2 millimeter diameter under octopus. And right panel shows the movement under octopus and Landiolol. Can you see any difference? Okay. So here's the total result. And if we use the appropriate dose, the anastomosis site motion can be decreased about 30%, even under the mechanical stabilizer. And I'd like you to pay attention these two cases shown by white arrow. Mechanical stabilization is powerful. However, somehow, some reason, we have to manage a few cases with bad stabilization, even under the mechanical stabilization. In summary, octopus has a powerful local effect. However, it depends on local factors such as tortuous coronary artery or much surrounding fat tissue, etc., etc. Because beta blocker has a global effect, it works when you have a poor stabilization under octopus. In addition, beta blocker could have some beneficial effects listed here. There is an interesting recent report by a coronary trial group trying to assess the risk factors and outcomes of converted patients. And they found conversion is associated with worse outcome compared with no conversion group. Yes, I agree. And they demonstrate that a conversion group has worse mortality after 30 days and even 1 year follow-up, with several post-operative morbidities as shown here. And then found independent predictors for emergent conversion as follows. One of them is non-beta blocker use, so suggesting a beta blocker may prevent emergent pump conversion during off-pump Cabg. So here we have done some other experiments on coronary artery motion analysis. Let me introduce you briefly. Next is use of catecholamine. Here's an example. The left panel is octopus only. The right panel will be when you ask your anesthesiologist for dobutamine. So you can see, and I don't recommend dobutamine or dopamine if you are if you're trying to make a perfect anastomosis. The next question is, which drug do you use to keep the patient's systemic blood pressure? Phenylephrine is an alpha receptor stimulant that contracts peripheral arteries. Noradrenaline is catecholamine. Here is the result. You can see noradrenaline significantly increase the motion when compared with phenylephrine. That means it makes surgeon to hard time to make a precise anastomosis on beating heart. And how about the ventilation mode? The upper panel is shown the coronary artery movement with mechanical ventilation. The lower panel shows non-ventilation. You can see the difference of coronary artery motion even after the application of stabilizer. Here you can see if your anesthesiologist increase the tidal volume, the motion of anastomosis site increase. This is what we have learned from our experiment. Catecholamine is not good. Remifentanil is okay. Noradrenaline not good. Phenylephrine is okay. Pacing is fine. Ventilation is also. So this is the summary of my talk. Actually, in short, please remember a beta blocker may be beneficial for OPCAB if you are in trouble. Thank you very much.
Well, excellent overview. So, any questions, please? Any question?
Thank you very much for a nice experimental study. And actually, when I do an off pump, still the off pump, the heart rate is very important for the stabilization, for the not for the patient, not only for the patient, but also the surgeons also. Surgeon stabilization is very important, and maybe I prefer the around 60 or 70 beat would be better than 90 beat or something. So what is your optimal heart rate? Maybe if you use a beta blocker, the heart rate won't come down. No?
It's a very nice question. And actually, we have done a few experiments of the which is better, the bradycardia or tachycardia. And in regard to the coronary artery motion, bradycardia is bad because stroke volume is big. Bound. So tachycardia is good. Very, very small movement. It's interesting. So maybe you prefer a heart rate of 60 or 70 and feels good. I agree with that. But if it's going down 40 or 50, it's gonna be a big movement. So I always using pacing, ventricular pacing, and keep them around 70 or 80. It's very comfortable for me to make a precise anastomosis, and it's very good for the patient for keeping hemodynamics.
Okay, thank you very much.
Any questions from the audience, please?
Any off-pump surgeon? No?
Yeah, sometimes when you do the off-pump anastomosis, when you lift the heart, especially to do the lateral anastomosis,
Right, exactly.
the BP will drop.
Right.
And then the anesthesia will give some medication,
Right,
and
right.
the heart rate will increase. So
Yeah.
this is sometimes difficult moment.
Right, exactly.
So what's your opinion?
Yes, I show you the difference between phenylephrine and noradrenaline. So some anesthesiologists give adrenaline or noradrenaline. It's very, very bad for me. A movement is getting vigorous, so it's hard to get a good anastomosis for the surgeon. So I always ask my anesthesiologist just to use phenylephrine little by little. Don't use catecholamine. It works.
Great. So if no question, we successfully conclude this session, and feel free to go have a cup of coffee. Thank you very much.
Thank you.
Excellent. Thank you very much. Yeah. So today is a 2-to-1 ratio. Very good.
We work too hard.
Very good. But your video are very nice.
Thank you.
Conclusion.
I give you my slide.
Thank you very much.
Restudy again. I know you are concluding.
I think its most important thing is the surgeon feel comfortable. Yeah, whatever you're comfortable to do, you just continue to do it. You don't have to be forced to do other people teach you.